Hello, everyone. Welcome. We're going to give everyone just another second or two here to get on to the webinar. So I just wanted to start by welcoming everyone and thanking you for attending our webinar this evening. So while everyone's logging in, I want to introduce myself and tell you a little bit about the Heartland chapter. My name is Amy Onder, and I'm the president and CEO of the Heartland chapter. And also with us tonight is Becca Rich, our events and operations director. The Heartland chapter is part of a national force dedicated to providing education and support to people living with lupus and funding vital lupus research. Our main office is located in St. Louis, and we cover the entire state of Missouri, Southern Illinois, Central Illinois, and Eastern Kansas. We have a number of great educational webinars coming up in the next few months that I wanted to just mention to all of you. We have part 3 of our Navigating the Pediatric Lupus Journey, focusing on preparing for life as a young adult with lupus, and that's on February the 19th. Lupus-related hair loss with Dr. Amy McMichael from Wake Forest, that's on March the 10th. And bringing lupus nephritis out of the shadows with our partner All In for Lupus Nephritis, and that will be on March 31st. We also host 2 monthly lupus support groups, which currently meet online or by phone, and our next support group meets tomorrow night from 6:30 to 8. The best way to get this information and stay informed about upcoming programs and events is to go to our website at lupus.org/heartland. and sign up to get our email updates, or you can also follow us on social media at Lupus Heartland or LFA Heartland. Before I introduce our panelists for this evening, I want to remind everyone that the information that's being provided tonight is informational and should not replace the advice of your own physician. Our doctors don't know your specific medical history, so they're not able to comment about any specific questions regarding your health. We had dozens and dozens of questions submitted in advance, and we hope to answer as many as possible this evening, but we may not be able to get to all of them. If time does allow at the end of the webinar and your question still has not been answered, you can ask a question by typing in the question box in your on the side here. This webinar is also being recorded and will be available on our YouTube channel in a few days. So let's get started. I'm pleased to introduce our panelists for this evening. Dr. Rachel Presti is an associate professor of medicine and medical director of the Infectious Disease Clinic Research Unit at Washington University School of Medicine. And Dr. Alfred Kim is an associate professor of medicine at Washington University's Division of Rheumatology, and he is the co-director of the Lupus Clinic at Washington University. Dr. Presti is going to start us off tonight. She has a few slides that she wants to go over, and I think these are more general about the vaccine, not specific to lupus. And we feel like these are going to answer a lot of the questions that were asked, just kind of general questions, and then we'll get into specific questions. So Rachel, I'll turn it over to you.
Okay, are you seeing my slides?
Yes.
Yes, okay, so yeah, so this is just some basic information about the vaccines. This is not to go over in a whole lot of detail, but just sort of a reminder that the immune system is a lot more complicated than just antibodies. We tend to talk about antibodies a lot when we talk about vaccines, but just to remember that both the infection and the immune response that gets generated by vaccines starts with stimulation of the innate immune system, a lot of cytokine release. There's a lot of T cells and other cellular immunity that actually gets stimulated as well, and then eventually you get the antibody response, and that's what we look at as sort of the protective immune response, but it's not the entire immune response. So, and this is just kind of summarizing the same thing as well for the adaptive immune system. Just to remind people, even though we talk a lot about antibodies when we talk about vaccines, because those are associated with protective immunity, that there are other cells that are important as well. This is just to remind people that when you have an initial immune response, you activate those B cells and you make antibody, but it's kind of low level and it's not as clean. It's not as specific and targeted. And then when you get re-exposed, you get a better immune response. You get a higher number of antibodies. They're more specific to the target. So this happens both when you're talking about vaccines. That's part of the reason why giving 2 vaccine doses gives you better antibodies than just giving 1 vaccine dose. But also that's how you get protection, because instead of seeing this as first infection and repeat infection, if you think this is first injection and repeat injection, that means when you see the virus, the SARS-CoV-2, the next time you'll actually have an antibody response and the other T cell responses that will help protect you. So how do vaccines work? Vaccines introduce sort of a weak or inactive form of the disease, and that's the traditional form of vaccines is a weak or virus or pathogen, or a killed virus or pathogen. What's become new in vaccines that have been developed more recently that makes them a little bit less likely to have off-target side effects, a little bit safer, especially if you're talking about the weak forms of the disease when your immune system doesn't work very well. It's actually much better if you just figure out what part of the immune system you need to stimulate and what antigen, what part of the virus or the pathogen is going to give you protection when you have an immune response to it. And so, after you see this, then your body responds by making those antibodies that are protective. And then when you're exposed to the virus or the pathogen, you are protected the next time. And so the vaccines for COVID right now that are available are RNA vaccines. And we talk about them as new kinds of vaccines. But to some extent, they're to some extent kind of one of the cleanest forms of a vaccine. So what we've figured out with SARS-CoV-2, with the coronaviruses, is that those spike proteins, and if you look like on the bottom where there's pictures there of the virus, that sort of classic picture that came out from the CDC, those spike proteins are what's on the outside of the virus. So you could imagine, and we've shown with science that it's true as well, if you have antibodies against those spike proteins, they're going to see the virus before the virus gets into your cells and establishes an infection. And so if you make an antibody response against that spike protein, that might be all you need to protect yourself against being infected with SARS-CoV-2. And so what the RNA vaccines do is they just give your body RNA, which is how your body codes to make proteins. So it's kind of like the blueprint for making the spike protein. Now, RNA by itself actually stimulates the immune system to some extent, but it's also not very stable if it's just left, open. And so they coat it with lipids, which is just like your cell membranes, and that sort of protects it until it can get into a cell, gets into your cell, and it basically tells your cell, okay, make spike protein. And it makes a bunch of spike protein, and your immune system says, that's not a protein I know, I'll make an immune response to it, and it makes it an antibody response and actually also a T cell response to the spike protein. And we know that that is effective. So this is the first RNA vaccines, this is the first RNA vaccine that's been approved for use in people, but that doesn't mean that this is the first RNA vaccine that people have worked on. So people have worked on RNA vaccines for Ebola, for some of the other new viruses like Zika, for HIV, for influenza. So there hasn't been an RNA vaccine that has made it to being used in the clinic, mainly because either the pathogens sort of went away on their own, or another vaccine became available, or it wasn't something that we could get that worked better than what we already have. And so it turned out, though, that these vaccines were the ones that worked first in the vaccine development for SARS-CoV-2. So there's some advantages to using the RNA vaccines. There are some other vaccines also that we're hoping will be available soon. And the 2 that are coming up are by Janssen and AstraZeneca. Those are both viral vector vaccines, and basically what they do is take a cold virus, adenovirus, and they change it so that it can't replicate, so it can't cause a cold, it can't actually replicate itself in your body. But it does look like a virus, so it stimulates an immune response. And then they make that virus make the spike protein. So they put the DNA for making the spike protein into those viral vector vaccines. And so they also stimulate a good immune response, both the innate immune system and the T and B cell immune system, and you get a good response to the spike protein. So some of the disadvantages to those vaccines are that you have to grow them in special cells, and so it takes a little longer, which is why they weren't the first ones to come up and be available. So the RNA vaccines, some of the advantages of those, you can see at the bottom there, they're not infectious, they don't integrate into your cell, they naturally degrade within a couple hours after they've given your cells the information to make spike protein. The RNA then is degraded, so it doesn't stick around. There's no egg or cell that might be also mixed into the vaccine. And it's pretty fast to make. So creating RNA and changing RNA in the lab is actually very, very easy. So they stimulate a decent immune response. The main disadvantage to the RNA vaccines is what we've been seeing in the rollout with the vaccines, is that you need to keep them very, very cold. And because they aren't stable if you let them sit out on the counter. So that's the main disadvantage that we've seen with the RNA vaccines. I talked about this already, so I'm going to kind of skip it, but this is just kind of the data that shows that if you have an immune response to spike protein, and spike is those little blue things that are sticking out, like little spiky things that are sticking out on the model of the coronavirus there on that far left. And then it's kind of blown up in that picture with the blue and the gray and the purple. If you vaccinate an animal against spike protein, you can see on the right there that virus doesn't grow. Whereas if you don't vaccinate those animals, all those squiggly lines just show how much virus was growing in those animals. So this is kind of an important point, and I don't know if there are a lot of questions about it, but we see it a lot. The thing that we should remember is that the vaccine response is against spike. And the virus isn't just spike. So there's lots of other proteins in the virus. There's that matrix protein and nucleoprotein. There's a bunch of other things in the virus. So if you're infected by SARS-CoV-2, if you get COVID-19, your body will make immune responses to the spike protein, but also to all these other proteins. And because of that, a lot of the commercially available tests for antibodies actually were developed against the nucleoprotein, not the spike protein. So getting your antibodies checked doesn't mean that you got vaccinated or that your vaccine worked. It won't give you the titer of your antibody response to the vaccine if it's measuring the wrong antibody. It's measuring the antibodies to nucleoprotein and not the antibodies to spike protein. And so we've had a lot of folks who've gotten vaccinated and then they worry that about how good their immune response might be. And so it's really, really important that you do this in the context of your doctor, or you do it in the context of of a study where people are they are sure that they're measuring the right thing, because just going and getting an antibody test is just going to cause you a lot of worry because you got the wrong antibody test, basically. I'm going to actually skip this. This is just showing the different kinds of vaccines that are being developed. And the two that are available right now are both RNA vaccines. That's Pfizer and Moderna. The two that we expect to be available maybe next month even, if everything goes well, are AstraZeneca and Janssen, and those are those adenovirus vector vaccines. And then there are some more vaccines that are in clinical trials now, especially Novavax, that are a little bit more old-fashioned, a little bit more like the hepatitis B vaccine, where they made the spike protein and they mix it with something that stimulates the immune response. and then they use that for the vaccine. So those are the vaccines that we know about right now. There are some inactivated vaccines where they took killed virus. One of the Chinese vaccines is like that. Those aren't the vaccines that we're using in the US right now. I think this is actually the slide that I wanted to show the most, because I think a lot of the concern that people have about the vaccines is that is a concern that we did this too fast, and that we skipped steps and we didn't do everything that we should do. And so I think the best response to that concern is just to show you the actual data and the actual numbers. So the reason we did this fast is because we're in the middle of a pandemic and we needed the vaccine as quickly as possible, obviously. And so we tried to remove barriers to vaccine development. And one of the major barriers is having the money to keep a vaccine in development, to raise money. So you have to, do your initial tests and then convince people who have money to give you more money to do more testing and to expand it. And so because there was money available from the government, from other agencies to move these vaccines forward as soon as they looked like they were promising, that allowed us to do this more quickly. The other thing is we enrolled tens of thousands of people into the vaccine studies. So if you look at Shingrix, which many people are familiar with, the shingles vaccine, there were 15,000 people enrolled in that phase 3 study. And it took them a couple years to enroll those 15,000 people into that study. So the Pfizer vaccine in their phase 3 study, so this isn't the total number of people who've gotten the Pfizer vaccine. This is just the people in the big phase 3 efficacy study. They enrolled 43,000. Moderna enrolled 30,000. AstraZeneca has enrolled actually quite a bit more in the US study. They are planning, or they've just completed enrolling around 30,000, but they have other studies in other parts of the world. Janssen has actually enrolled about 45,000 people to their study. So you can see we enrolled a lot of people, and it didn't take us 2 years. It took us really like 2 months to enroll this many people into these studies, because so many people were willing to do the studies, because so many people knew that this was important, and because so many research sites were trying to enroll people as quickly as they could, seeing as many people as they could, working on weekends, working long hours, having shift work and stuff to get as many people enrolled in the studies as quickly as possible while following all the same safety parameters. So I just want to point that out. The other thing that we should point out is there's been a lot in the media about did we enroll the right people? And we should know that since SARS-CoV-2 has the highest mortality in people who are older, there was always a strategy to enroll people who were over the age of 65. So at least a quarter of the people enrolled in these studies were over the age of 65, because that's the population we need to know whether or not it works in that population. And because in the US, persons of color were more likely to be infected by SARS-CoV-2, about 30% of the enrollees in these studies were not Caucasian, were other people of color. So while there was a lot of concern that we might not be doing this, in the end of these studies, and a lot of work was put into that, I think they're fairly representative of the populations that are at highest risk. And then the other thing you need to show that a vaccine works is you need endpoints. So you need people going about their daily lives, not infecting them, but their normal daily routines. You need people to get infected. And so for the Shingrix vaccine, they got around 200 cases of shingles and were able to demonstrate about a 90% efficacy because most of those cases were in people who got the placebo and didn't get the vaccine. In Pfizer and Moderna, we saw almost 200 cases of SARS-CoV-2 to demonstrate the 95% efficacy, that difference between people who got the placebo versus people who got the vaccine. And you can see there, 162, 185 cases in the placebo, 9 were severe, 30 were severe in the Moderna study, where there was only 8 cases and 11 cases for Moderna in the vaccine arm. So, and very, very few severe cases were seen. So very, very protective against symptomatic infection. And because there's so many people getting infected by COVID-19 right now, that number of cases was able to be accrued. We had that many people getting sick within really only about 2 months. Whereas when you compare that to the Shingles vaccine, that took about 3 years to get that many cases. And so you can see that we have the same, we have more people, we have more safety data, we have just as many cases. It just happened faster because of the fact that we're in the middle of a pandemic. And you can see for some of the other vaccines, these were large vaccine studies. We have a lot of information. The other thing, because people worry about safety with these vaccines, what we've seen with vaccines in general is that the safety signal for almost all vaccines is really seen in the first couple months after getting vaccinated. And so the FDA said you need at least 2 months of follow-up on people after their vaccine before they'll even look at the data. And so the safety was very good. They did see a lot of injection site pain, fatigue, headache, muscle pain. For the most part, that lasted a day or two. It's a little worse with the second vaccine, and then it sort of goes away because there's no virus there to actually continue to stimulate the immune response. So those side effects are really, really consistent with side effects you would expect from just having our immune system stimulated very strongly. And then I think this is maybe the last slide I want to show, but this is just, I think, the slide that really demonstrates the science of it. So the people in blue, those are people who got placebo. They got a normal saline saltwater injection. That line below that, that pretty flat looking orangey red line, those are the people who got the vaccine. And you can see that even after just 1 dose of the vaccine, by 14 days after the first dose of the vaccine, those 2 lines really, really separate. And you can see how quickly there were cases of coronavirus in people who had gotten the placebo, and how protected people were from getting infected who'd gotten the vaccine. So I think that's just really, really very dramatic and does help people sort of visualize how well the vaccines work. You see the same thing with the Moderna vaccine, same kind of curve. So I think we'll talk about this more answering questions. I know there are lots of questions with this group about immune suppression, and it is a bit problematic because people weren't studied if they had significant immune suppression. And that was mainly because the vaccines, they needed to demonstrate whether or not they worked in people who could make a good immune response. And so, so that's the way the original studies were designed. I know Dr. Kim will talk more about what people are doing now to try to see what happens in terms of the immune response and efficacy of the vaccines in people whose immune system isn't as strong. The reason to exclude people who didn't have a strong immune system had nothing to do with a safety concern. These vaccines, they don't replicate. They're not going to cause any more problems if your immune system isn't working than if your immune system is working. So, so there's not a safety concern. It's just the concern that it might be not as effective. And the other situation is for pregnant women. So it was not studied in the trials because there are so many extra protections for pregnant women that really need to demonstrate safety and efficacy in people who are not pregnant before you can study people who are pregnant. But there's no safety concern in animal studies. They're not live vaccines. They wouldn't be expected to get to the fetus. And the recommendations by the OBGYN folks are to go ahead and get vaccinated if you are pregnant and at very high risk. it's worthwhile pointing out that even though we tried desperately to tell people that they shouldn't and couldn't get pregnant on the studies, there were pregnancies in both the Pfizer and Moderna study. Not a lot, but enough that there was no difference between the placebo and the vaccine group and people who got pregnant. I'm not sure that there's a question about it. If it comes up, I can talk about this. People do want to know about the variant viruses, and I think this is an area where we're going to actually learn a lot more in the coming weeks and months. Right now, it looks like the vaccine should work against the variant that is coming out of the UK. They might be slightly less effective against the variant coming out of South Africa, but still potentially effective. I think also we'll have data with the Janssen vaccine and the AstraZeneca vaccine because they are conducting those studies in the UK, South Africa, and Brazil. So we should be able to see at that point if the vaccines still work against those variants. So more information to come. It also does mean that we don't know if there may be variants in the future that may require that we need to change the vaccine or may require that we need to give people a booster that covers a different variant. So all of that is kind of unknown at this point. So the other thing to keep in mind is people measure their antibodies a lot in the serum to look at immune response, but looking at longitudinal, it's expected your antibodies would drop a little bit, but it looks like you actually have a good memory B-cell response, and you would expect that there is immunity that lasts. This is information from 6 months post. These are people who were infected. We're hoping to get more information about people post-vaccine, but the immune response lasts longer than I think people had expected. Okay, I'm gonna. How do I stop sharing my screen?
I think if you just click the sharing screen, yeah, there you go.
Okay, did it go away? Okay.
Yes, it did. Okay, great. That was very helpful. I think what we'll do now is just go into some of the questions. I've kind of went through some of them that you have answered quite a few of them, which is great. We're going to start with just some general questions that Rachel's going to answer, and then Al will answer specific questions related to people with lupus. Can someone who has been vaccinated still spread the disease?
Yeah, so yes, probably. We don't have good quantification of that, but the recommendation is right now, what they measured in those vaccine studies, that line I showed you that showed the dramatic difference, what they measured was symptomatic infection. So, so positive coronavirus and you were sick. You had, you had fever, you had cough, you had symptoms. They did not look, at least they haven't published all the data yet. They didn't look to see if people shed virus when they aren't symptomatic. And we know that people shed virus. We know that people get infected and shed virus even when they don't have symptoms sometimes. Maybe a third of people who get infected may not have any symptoms. So we don't know that the vaccines protect. There's some information that probably the vaccines do protect to some extent, but they're not 100%. And because of that, and because we're still in the middle of a pandemic with very high rates of coronavirus and very high numbers of people in the hospital, we still need people to wear masks. We still need people to socially distance until the epidemic is under control, not just until you get vaccinated yourself.
That's great. There were a number of questions about that as well. Should I still wear a mask even after I get vaccinated? And the answer is yes.
Yeah. There are two things. There's protecting yourself and there's protecting the whole community. And until we actually see the numbers decrease, we need to do everything we can to protect the whole community, which means keep doing everything that we're doing in addition to vaccination.
How long will the vaccine's protection last? Might we need to get vaccinated again 6 months to a year from now?
I don't know because we haven't seen people who've been vaccinated for more than 6 months or so. So, those initial vaccines went in people's arms in July. And so, we're 6 months in or so. And it looks like there's still protection. But I think this is ongoing information. We're going to have to keep looking. And there's a couple of things. Does the virus go away? Does the virus get under control? And you're not being exposed anymore? And then you don't need to be, we don't need to give people smallpox vaccine now because there's not smallpox circulating. But then there's also, are there variants that come up and now we need a new vaccine to cover the variants? Or do we lose immunity and we need to boost immunity at some point? And this has been true for like every vaccine. As there's more and more time and more information, we realize, oh, you know what? People need a booster at 5 years, or people need, we need to change the vaccine. We can't predict that yet.
If I already had COVID, do I need to get the vaccine?
So the recommendation is that you get the vaccine if you've had COVID, mainly because, so all viruses, when they infect you, they do a lot of things. And yes, you have a protective immune response. We know it's probably protective for about 3 months, but they do a lot to decrease your immune response and interfere with it. And so it looks like the immune response you get from the vaccine is a better immune response and a stronger immune response than you get after just being infected. And so the recommendation is to go ahead and get vaccinated. Now, you should wait until you are, not ill anymore from COVID, that you're not in quarantine, that you've recovered. And there's some recommendation that you maybe even wait up to about 3 months, because the data is pretty good that you're probably protected for 3 months. So.
Great. How long after you receive the second vaccine are you fully protected?
So that is a little bit dependent on which vaccine you get, but generally a week to 2 weeks after the second dose is when they started measuring, and that's when they got that 95% efficacy. But like I showed you on those graphs, you actually start to see protection even 2 weeks after the first dose, so before you even get the second dose.
How far apart should I get the COVID vaccine with other vaccines like the flu shot or shingles?
So the recommendation in the studies was 2 weeks to 30 days for was really mainly 2 weeks for the non-replicating vaccines, so the not live virus vaccines. So things like the flu vaccine, the Shingles vaccine, most of your vaccines are not replicating, not live virus vaccines. And for those, the recommendation was to wait 2 weeks. Some of that is just, getting more than one vaccine does make you feel sick, and there are side effects with this vaccine. So.
You've already said this, but I think it's worth mentioning because we got several questions. Can I get COVID from the vaccine?
Oh no, yeah. The vaccine is just spike. And so there's not enough information in the vaccine to make a virus. All it tells the body to make is, all that gets expressed is the spike. You can't get infected from the vaccine.
A lot of people were nervous about, they've heard that people are getting these really bad reactions from the vaccine. And a lot of people are saying, what happens if I have a bad reaction? I've been reading that they're going to make you sit there for a little while to make sure you don't have an immediate reaction, correct?
Yeah, so they'll watch you for about 15 minutes. I don't know how closely they watch you. They have you sit close by so that if you're having a problem. If you've had a history of severe allergic reactions, anaphylaxis, where you stop breathing from another medication, they've been watching those folks for about 30 minutes just to be careful, because they're, sort of makes you wonder, like, why people who carry around an EpiPen and have had anaphylaxis to multiple things, why were they the first people who lined up to get vaccinated in England when they opened up the vaccines? But they did, and so they've seen a couple reactions. It is a small number. So the CDC published in the first 2 million people who got vaccinated with the Pfizer vaccine, I think they had 200 potential cases of anaphylaxis. So and those folks, some people were hospitalized, but those folks were all treated and recovered. So the concern is that severe allergic reaction. We haven't seen, other than that, yes, especially the second vaccine. For some reason, especially in the younger folks, it seems like, at least has been our experience, you feel kind of crummy. You feel like you've gotten sick. That is a sign that your immune system is active. It's working hard and it's trying to make an immune response. And so people have, you know, achy bones and maybe a low-grade fever. And, you know, so if you get the vaccine, when you get the vaccine, you know, just make sure you're not planning on doing anything too important or exciting the following day. So, you know, be prepared. You may want to just kind of lie around at home the next day.
Can children get the vaccine?
Right now, Pfizer is okay down to age 16. So the 16 to 18-year-olds, and the studies are ongoing, but right now there's no approved vaccine for kids.
Okay. What are the chances that there will be good and affordable access to testing for immunities? And if so, when might we expect that? I think a lot of people were asking about knowing if they had already been exposed to it.
Knowing if they've been exposed. So it's not that hard. Yeah, it's not that hard to go get an antibody test. I think to some extent people have been getting antibody tests. Make sure you understand, I mean, talk to your doctor about getting an antibody test before you do it. I think there's a lot of misunderstanding about what they actually mean. They mean that you've been exposed to something. They don't mean that you're actively infected. They don't mean that you're immune even necessarily, although they might. And to my knowledge, there aren't a lot of antibody tests that give you an actual number that tells you, okay, if I'm over 10, I'm good, and if I'm under 1, I'm not covered. We just don't have that information yet. So sometimes having a test done where you can't interpret it is worse than not doing it at all, because it just leads to more confusion. So I think there are a couple of answers to that. One is right now, I don't think you need to get an antibody test. I don't think you should change the guidelines and view what you do based on some other test until we actually have information that it's interpretable and reasonable.
Great. Now, I know a lot of people had questions about how can I get the vaccine? And I want to preface this by saying I think we have people from all over the country on this call. So I know you're not going to know that for every state, but in general, what's the best way for people to go about signing up to get the vaccine?
Oh, you know, maybe Al has an answer to this. I think, you know, this is one of the problems with the vaccine rollout is it's very, very scattershot. There was an article I was listening to on my way home on NPR where in California, the tech folks, they're actually crowdsourcing a website to tell people where they can get a vaccine. I think that's an unfortunate problem that we have with the public health infrastructure in this country. You know, you should be able to tell from, you know, I would start with your doctor. I would start with your local health system, so big healthcare systems in your area, and then the public health folks. Hopefully on their sites they'll give you some direction as to where to go.
Yeah, I also saw that you can sign up through St. Louis County and St. Louis City. Yeah,
the public health departments should have some way of at least signing up to get information and get on a list or a registry. Yeah.
So I just want to remind everyone that each state has COVID vaccination websites that are online active. You can get a lot of information about how to proceed with putting yourself in line for a vaccine. I think in Missouri, essentially everyone's going to be pre-registering through a website. I know Barnes has its own separate pre-registration for many of its patients that are seen in the WashU Barnes system in the St. Louis area. So basically go there, you pre-register, and then essentially you're kind of waiting in line until your turn is up, and then you're notified about when to schedule your vaccine. Again, how this is going to roll out is going to be very interesting, especially at the general public level. So there are going to be some hiccups, I'm going to anticipate. We're going to have to be patient. I think there's going to be a faster rollout with Biden's initiatives that he presented today, or at least he's going to try to improve the speed of the rollout of the vaccine. So again, this is a very fluid situation, and we reserve the right to change our answers tomorrow.
Absolutely. Okay, just another one or two questions for Rachel, then we're going to turn to Al. One of the questions that we had, and I know this is in the news just recently, is should we be wearing 2 masks?
Yeah, so I just heard that as well. The whole mask thing is interesting, and there's a lot of data, that and guidance that kind of varies in part depending on what's available. So part of the reason, like ideally everybody would wear an N95, but we know that there aren't enough N95s, and we know that the N95s or the KN95s that you can get online, not all of them are legitimate. They may not be giving you the protection you need. And so yeah, there's some data that's just come out that maybe ideally what you should wear is a surgical mask with a cloth mask over it. That may be giving you more protection. The surgical mask has the good filter, and then the cloth mask makes sure it like fits on your face. So regardless of how you actually wear the mask, the important thing is that you wear a mask that covers your nose and your mouth and that isn't like leaking and gapping out air. So when you breathe in and out, the mask should move, but you shouldn't feel air like leaking around the mask, is what's really important. And you don't want to, like, if 2 masks is good, that does not mean that 3 masks is better, right? If you get to the point where you can't breathe, that's also not a good thing.
Great. Okay, let's switch to a couple of questions for Al and Rachel. I think you can kind of chime in if you've got more things to add. But obviously the number one question I told Al that everyone has asked is, I have lupus. Should I get the vaccine?
Yes, hard stop, move on. And the reason why I say this is not because I want to be flippant. It's just, the argument that lupus patients weren't studied, and I know that's going to be another question. That's true. Lupus patients were not part of the original clinical trials. And I know on social media, there are a lot of patients with rheumatoid arthritis and lupus are really angry at Pfizer and Moderna about this. I think the one thing everyone needs to realize is how difficult it was to be able to do this in less than a year. Nothing has moved at this particular level of speed, but also at the same time, they were very careful to make sure that everything was done correctly. And as Rachel very accurately pointed out, we needed to know first whether it's just going to work, period. And so, that's the reason why a lot of the immunosuppressed people were excluded, were 100% excluded from the trials. So the one thing I want to tell the lupus patients, though, is that we don't ask these questions about the other vaccines, even though lupus patients are not part of those trials either. Right. And so there is a great deal of safety data that is more based off of you and your other lupus patients that are here who've received vaccinations and have done okay. So I think this is going to be something that we're going to probably end up seeing not being an issue, is safety. I think these vaccines are going to be safe for lupus patients, and as a result, that's the first thing we want to protect is your health. So we want to make sure that the other thing too is that lupus patients are at an increased susceptibility of having more severe outcomes due to COVID-19 than non-lupus patients. So that's another reason, and maybe a more important reason, to get vaccinated.
Great. What about people who have lupus and then other health issues or other autoimmune diseases? And I know we're getting maybe a little too specific because you don't know what they're talking about, but I think there was a lot of concern that, as you know, people with lupus often have multiple autoimmune diseases.
Yeah, I think the answer still holds the same. I don't think the vaccine knows that you have an autoimmune disease or not, or 5 autoimmune diseases or 2 or 1, right? So I think that, again, the safety data about all the other vaccines more based off the real world experience, what we do every year with flu or every several years with pneumonia, that, that's also been given to people with multiple autoimmune diseases. There's nothing unique really about how, what this vaccine that we have, other than how it's given or how it's made up. That's the only thing that's different, but its effect on the immune system is the same effect as other vaccines. So I think there isn't, again, this highlights again the kind of the lack of concern that we have about the safety, actually, generally speaking, for autoimmune patients.
A lot of people were concerned that when they get the vaccine, could they get a flare from the vaccine?
So this is a really good question. And so before I actually understood the mechanics of the vaccine, I would have said yeah. And the reason why I would have said yes back then, I've changed my mind. Why I said yes back then is that RNA tends to be a very potent stimulant of lupus flares. Well, now you think, oh, this is an RNA vaccine. I'm gonna get more RNA. This is gonna be a problem. But one of the things that was done to make the vaccine actually a little bit more stable, they made a couple changes to the molecule itself. So it's actually not truly the same as what is found in the virus. Those changes actually reduces its ability to stimulate immune responses that then drive lupus flares. We call this the interferon response. This is something that we've been chatting about in other webinars as kind of an important immune pathway that drives lupus flares for in about 2/3 of people. Again, so my first gut instinct was like, oh no, this is going to drive these interferon pathways to go up, and this is going to cause more people to flare. But the reality is that these modified RNA molecules that are being used in the vaccines do not stimulate those pathways very well at all. So I'm actually now much more confident that people more likely are not going to flare with this type of vaccine. Now, there are certain vaccines that in small papers that have argued that there might be some increased risk of flare in lupus patients. Again, everyone is going to be different about this, and this is part of the frustration for patients. I get it. Everything we report in the study is based off of saying, oh, we have 4,000 people and we're going to treat them as one person and describe everything as one person. Well, where do you fit in those 4,000? You're not going to be that one person. And I'm not a magician, neither is Rachel, surprisingly, right? And we can't, that's the risk a little bit with these type of things, but this is not any different with starting a new medicine or anything like that. So again, this is the type of discussions you have with your family, with your physicians, but in general, the discussions I've been having with my patients is that I think the general risk of flaring or having any safety issues is much lower than the risk of having major problems if you happen to contract COVID.
Have you had any patients, lupus patients, that have gotten the vaccine?
Yeah, we've had about, I just closed it. I can give you a very specific number, actually, because one of the things we're doing is we're trying to, I just hit the wrong button here. It looks like right now we have about 15 people with lupus who've received the COVID vaccine, and about 4 of them have already gotten the second booster shot. And so, yeah, so, again, so early, there's a difference between data and anecdote. And when you have more anecdote, it's still not data. All right. So again, I'm telling you anecdote, based off of what we know, based off of those 4 people, we haven't seen anything happen adverse event wise, maybe a sore shoulder, which is what I got, but nothing serious. So again, that's just 4 people. Once we get a bigger population, this is something we're more interested in able to study. I'm going to put the plug in right now and again later. Rachel really helped us start this study where we're going to be examining the responses to vaccines, both in terms of how well it works, but also its safety here at WashU in the St. Louis area. So if any patients that see me within my lupus clinic that are interested in getting the COVID vaccine, please reach out, because we are interested in being able to study how well does the response evolve and how strong does that response exist in lupus patients on various medicines, and of course how safe it is. Is it going to cause any side effects because of the vaccine, but also whether or not you flare. So we are well on our way in doing this study, and that's the reason why I know we have these people with lupus that have had the vaccine. So we need a lot more of these people in order to get us much more kind of solid conclusions. So again, reach out to me. Well, you can reach out to the LFA first, and then I guess you can kind of start feeding us people.
Yes.
Again, if you're a WashU patient, if you're a patient of mine, for example, you should have already received either by my chart or through your email the link to the Barnes pre-registration site for COVID-19 vaccination. So this is something that, again, it's still being put together really, but there are ways to be able to make sure that you can get your foot in the door.
And can you report that back to us when you have some results down the road?
Sure. No, I'm gonna hide it. I'll just keep it to myself and Rachel. Yeah, and then we'll have a glass of wine discussing it. Of course, we'll be, yeah. So we're actually doing this study with not just lupus, but also rheumatoid arthritis, psoriatic arthritis, psoriasis, people with inflammatory bowel disease like Crohn's disease and ulcerative colitis. We've already recruited over 100 people. And so we're anticipating, we're just going to report the first 100 people just kind of as a story of what we're experiencing here in WashU and in St. Louis, hopefully within about 5 or 6 weeks. We're anticipating that we'll be able to get that out. And as soon as we have something, a formal report put together, we'll let you guys know.
That's great. Maybe we can have another webinar.
Maybe.
Okay. Okay, so a lot of people asked about lupus medications and how they may affect the vaccine. Should they stop taking their medications? You know, can you just talk about that?
I can talk about it, and I'll start off by saying we don't know. You know, again, this is probably very frustrating for patients because I think a lot of patients may be feeling like that they're being forced into a situation where they can't see what's in front of them. Whether or not it's going to be space or a wall or a car. So I think that we are using now, you know, our experience with influenza vaccinations, pneumonia vaccinations, shingles vaccinations, and with those, the effect may be mostly dependent on the medicine itself. So the largest effect is actually with a drug, some of you may be on it, rituximab. That has the greatest effect in reducing vaccine responses. Now, if you're on rituximab, you may instinctively say, I don't want to get my rituximab anymore because I want to make sure I get a strong vaccine response. There is a difference. So Amy and I were talking about this earlier. I think one of the things that the press hasn't really done a great job of, and maybe us too, is talking about what these reduction in vaccine responses really mean. Rachel kind of touched on this, but you know, when we are talking about vaccine responses and changes in vaccine responses, you know, we're always putting the people who are not on immunosuppression as kind of the top tier. That's like the maximum we can hit, all right? And maybe if you're on, we have lupus and you're on drug X, it might drop a little bit. Maybe it drops by, you know, 20%, right? And you're immediately thinking, oh, that means I'm not going to be protected. That actually is not necessarily true. So there's a difference in terms of how much of an immune response you generate versus how much you need to be protected. I think a good example of this, and they haven't really shown it quite yet, is that Moderna has data showing that the Moderna vaccine generates about 6 times less antibodies to the South African variant of SARS-CoV-2. But the levels are still quite high, and they're actually thinking it's still protective, even though it's 6 times less, right? So think about that, right? It's not always about how much of a decrease there's going to be. It's going to be, is the decrease enough so I lose protection? Now, the problem is we don't know how to measure that for everyone, okay? So more unknowns, and I get it. Lupus patients are probably like, I'm logging off this. I haven't learned anything from it. But the thing is, that's the truth. And I guess, you know, Rachel and I are very comfortable living in this world of kind of question marks and ambiguity because we don't want to unfairly represent information, which has been done a lot in 2020. Think hydroxychloroquine, right? So I think that we want to make sure we're fairly representing what information we have, clearly telling you what we don't know. We can give you our best guesses, but again, Rachel and I reserve the right to change our minds tomorrow.
And it's not, we're not changing our minds willy-nilly. It's that if there's more information that comes out,
Exactly.
That's the way science works. And everyone thinks that, when science gives you an answer, that it's the be all and the end all, and it isn't. It's what we know. It's the data we have based on what we know. And
Right.
I think the same thing applies to why are we telling people to still wear masks? Because none of this is like, everybody wants to say, okay, if I do this, I'm totally protected. I won't get COVID-19. The only way to not get COVID-19 is to go live in a cave someplace and never be exposed to another human being. And then other horrible things might happen to you in your cave. But so if you're going to be in society, there are things you do that make you safer. And if and we don't want people getting COVID-19. So yes, if you wear a mask, you're safer. If you stay away from other people, you're safer. If you get vaccinated, you're safer. But none of that's 100%. And the same is true for your antibody levels. So if you have really high antibody levels, you're probably more protected. But maybe you have so much antibody, you don't need all that antibody. You only need 10% of that to be protected. And so then if you heard, oh, I only have, a 90% reduction in my antibody levels, that might still work. We just don't have all that information yet.
Still lots of questions about medication. So one of the questions is, like, before you get the vaccine, should you stop taking any kind of like NSAIDs, aspirin? People are asking about Benlysta. Any thoughts about any of that?
Generally speaking, I'm telling all my patients to continue everything. I think the thing we're most fearful of is if they stop their medicines and they actually flare, all right? Because if they're flaring, they may not be actually someone who may be able to get the vaccine at that time either. I'm just not convinced right now, because there's very little data, but it's also based off of what we've done in the past too, is that stopping the medicines. I know a lot of rheumatologists actually are telling their patients to stop their medicines when they're getting the vaccine, and I get why they're saying that, but there's actually that theoretical risk hasn't been fully realized. So that's the reason why I'm telling my patients to continue their medicines. I think a lot of this also depends on how comfortable the patient is, right? Again, we're living in the data-free zone, so everyone gets to make the decision, and their decision is always going to be right and wrong simultaneously. So until we get the information, so I think that again, my own personal position is that I don't want people to flare. And so even if we find a reduction in how strong of a vaccine response you get, I'm still going to make the argument that the response is going to be most likely still protective. I mean, that's what we're hypothesizing or anticipating.
I think the one thing to point out is for the studies, if people were not on severely immunosuppressive medication, they were allowed to be on the study. And the most important thing really for enrolling in the study was that you are on sort of a stable dose of your medicine. So I think to some extent you're best off actually being just at a really stable sort of state. If you've been good on the medicine you're on, stay on that medicine. Your body has adjusted, your immune system has adjusted to some extent to being at that level. And so, yeah, some of those medications may be immune suppressive to some extent, but maybe they're dampening down inflammation that's actually putting you at a different level. And this is all still hypothesis. The one thing just to sort of point out, we have been there are people who are really worried about having side effects with the vaccine. And what we've been telling people is, if you have a headache, if you have muscle aches and you like to take ibuprofen for your headache, or whatever medication you like to take, when you get those side effects, go ahead and do that. Please don't suffer thinking that you're getting a better immune response. But what we don't want people to do is, I'm afraid I might get a headache, I'm afraid I might feel badly, so I'm going to take a bunch of medication ahead of time to try to stave off a reaction that I don't even know that I'm having. because that's the situation where you're going to potentially suppress your immune system when you didn't need to. So we're telling people not to pre-medicate, but if you need to take medication, then take medication to deal with the symptoms.
That's good advice. A couple of people have asked, if I'm in a lupus flare, should I get the vaccine or should I wait?
That's a good question. I like to make sure that people are stable before we introduce anything into them, even a flu shot or pneumonia shot. I think the instability, associated with a flare, kind of puts people at a different risk of, if you're going to stimulate the immune system a little bit more beyond that. I don't know exactly what happens. In general, I don't vaccinate my patients with influenza vaccine until their disease is stable. I think it's just kind of one of these things I feel like a lot of my patients have told me when they get the flu vaccine, they don't feel great, even more so than their baseline, if they're having a flare. So I think this has been challenging, especially in this past year with like telemedicine and everyone trying to learn how to better doctor over a form like something like this. So I know some of my patients have had more flares than they're used to. So this is something that we're working really hard with our patients, is to make sure that can we get them as stable as possible, regardless of the medicines, so that they can get the vaccine. So again, there's no data to support this, and this is just purely my guessing. But I tend to want to have my patients to have as minimal of a disease activity issue than before getting the vaccine.
Okay. A few people have asked questions about COVID itself, like and I don't know, I know you were part of that rheumatology COVID project. Do people who have lupus have worse COVID if they get COVID?
Yeah, so I can think there are a couple issues here. So there was one question, if I were on steroids or if I were on drug, X, whatever, does that increase my risk of getting COVID? And then the second question, which is kind of unrelated, is if I get COVID, will it make it more severe? So the first question is about risk of getting it. So this is all about whether or not you're exposed to someone with COVID and whether that establishes an infection in you. Lupus patients are not at increased risk of having increased exposure. Or increased risk of getting COVID. This is purely a function of who you hang out with, all right? And how well they're masking, how well you're masking. This is purely just a function of that. Now, in America, we're, lukewarm good at this, all right? So the risk is not zero. But if you have someone with lupus who lives in that cave, and their risk is going to be zero, versus someone who doesn't have lupus, who's out and about in a restaurant unmasked with everyone else and that's crowded, they're at much higher risk of getting COVID. So again, this is independent of lupus. That has nothing to do with it. But if you happen to get COVID, contract it, the data does suggest that lupus patients are about twofold increased likely to have more severe symptoms of it, including death. Some of this may be due to the medications. We've already know that steroids increase the risk of death in these people, and actually, interestingly, rituximab has also been shown to increase the risk of death by about 4-fold. And I think a lot of this is because your immune system is largely impaired at the time of infection, and that's really kind of an important surrogate or indicator of future risk of having bad outcomes from COVID-19. So this is, again, highlights in my mind the need to vaccinate lupus patients and rheumatoid arthritis patients, et cetera. This is, the medicines do put you at some risk. The diseases sometimes will put you at risk. So if you get the vaccine, you can, can ameliorate, you can get rid of those risks and not have to necessarily worry about it. So again, the risk of getting COVID is no different than the public, but the risk of getting severe COVID once you get it is increased in a lot of our lupus patients.
A question for either one of you, but people are wondering if there's one vaccine over another that you would suggest for people with lupus. It sounds to me like the two are pretty similar, but do you recommend one over the other, or just get whatever one you can get?
Get what you can get.
Yeah, whatever you get. I'm not sure people are going to have a choice.
Right.
I think.
Yeah, this might become a bigger question a month from now, if AstraZeneca gets an emergency use authorization and Janssen gets an emergency use authorization, I don't know that we're going to have data to say for sure that you should do one or the other. But that's something that, you know, reach out to your doctor, get information on, because those are slightly different kinds of vaccine. But right now, Moderna versus Pfizer, I don't think there's any reason to suggest that there's a difference. So.
Okay. We've had a couple people who've asked questions about that they have blood clotting disorders, and is there any concern with that and taking the vaccine?
I would say people with blood clotting disorders are at increased need to get the vaccine. So one of the problems with severe COVID is that it can actually make your blood clot much faster. Many of the issues with stroke and heart attack is because of blood clots. If you have a clotting disorder, that actually puts you at increased risk of having bad outcomes from COVID. So that actually makes me think that they should be getting the vaccine earlier, or increase the need for them to get the vaccine. Again, I don't think that the vaccine itself is going to interfere with their disease, much like lupus or rheumatoid arthritis or any other thing, but it's going to be mostly about if they happen to get COVID. Those people would say antiphospholipid syndrome, which can be seen in lupus patients. You are really at increased risk, because actually we think that the pathways that drive clotting in antiphospholipid syndrome are the same pathways that drive clotting in COVID-19. All right, so your system is already primed to activate that axis. So getting vaccinated is going to be a really important thing for those people.
Okay, another question, a couple of people have asked this, is should you get your white blood cell count checked before you get the vaccine?
We don't check it for any other vaccine. I mean, it kind of is a theoretically interesting question. I don't think there's actually any data to support it, but I can't think of a reason why to check it.
Okay.
Rachel?
So to my knowledge, on the studies, we didn't check that before we gave the vaccine to people. Now, you know, we weren't enrolling people with lupus, but it wasn't part of checking to get the vaccine on the studies either. So.
Okay, I'm going to start to answer. We have maybe just a few minutes left, and some people have been, actually a lot of people have asked questions tonight.
Shocking.
And so I'm going to try to go through some of them. We've had a couple of these, but I'm not a patient of Dr. Kim, but how can I get the COVID vaccine to be part of the study? That's only for your patients or people at WashU, correct?
Yeah, I mean, we do have potentially the bandwidth, particularly for lupus, to get people that can come to our center. So one of the things about our study is that we're going to get blood, because we have to measure your immune response. There's going to be 7 blood draws over 6 months. And so we do them at the main WashU medical campus. So if it's really hard for you to get to us, it becomes harder for us to be able to enroll you. So that's kind of one caveat for everyone. Like if you live in Pittsburgh and you want to enroll, I can't necessarily recommend it, but if you feel like you want to fly or drive over here and give us blood, you know, God bless you, because I don't know if I would do the same thing. So again, a lot of this, these type of studies are hard to do, because literally, and Rachel knows this because she's doing a similar study with another study with healthy people, non-autoimmune patients. You know, we're literally, these studies kind of put together with Band-Aids right now. So, you know, we can't go big, we can't go national. That requires a lot more nickels and quarters than we have. So this is, again, I apologize for the national audience that we may not be able to study you per se, but what we're hoping is that the St. Louis region is going to have enough subjects and patients, and I think we will, to be able to give us a general good idea of what we're dealing with.
Another question, this is a good one, probably for Rachel. Will we know which vaccine we're getting, and how do you know when it's time to get the second vaccine?
Oh, yes. Oh, they'll definitely tell you which one you're getting. you'll get a little card that tells you which kind of vaccine you got. That's sort of for multiple reasons. There you go. You know, they want to give you the second vaccine the same kind. Right now, I know at least at WashU, they're scheduling your second appointment when you come in for your first vaccine. And so, you know, we're trying to follow what the study did as closely as possible. Now, again, as Dr. Kim has already said, these kinds of things might change. You know, I have been telling people with the discussions about whether or not we should be holding back vaccines to make sure we have the second dose for everybody who gets the first dose. There's a little bit of a problem in doing that if you're having problems getting people in for the first dose in the first place. So I think once you get people in for the first dose, you've got people engaged. You know, there definitely lots of people are afraid. This is new and it's a little scary, and just getting in the door is really important. So we don't want to put barriers up to people getting in, and so we don't want to limit the number of things we have. But in general, so the spacing might wind up changing. And right now we're recommending if you start with Pfizer, you get your second dose with Pfizer. If you start with Moderna, you get your second dose with Moderna. I think what happens in the world of vaccines is that, you know, reality sort of settles in. If you started with Pfizer and then all of a sudden there's a huge, you know, supply chain catastrophe, and there is no Pfizer available, it's probably better to get Moderna then for your second dose than to get nothing. And so these things might change. So there's like the ideal, which is follow the rules of the study, and then there is do the best you can, which is what we see all the time. You know, the only people who get the vaccines when they're supposed to get their vaccines are like babies, when their whole pediatric schedule is based on bringing them back for their appropriate vaccine appointments. You know, adults are never great about following up exactly when they're supposed to, and you know, the vaccines still work. So, and we'll have more information about that as more and more people don't do exactly what they're supposed to do. So.
Okay. I'm looking through the questions. I think we've answered quite a few of these. Some I'm just going through. If my spouse has Parkinson and I have lupus, would you recommend getting the vaccine at the same time if possible, or does that make a difference?
So if it's easier for you, you know, if it's a chore to get to your doctor, then do it at the same time. I guess, you know, I've gotten it, and then my husband enrolled in a study and it was probably a good thing that we didn't get it at the same time, because if one of you, especially with the second vaccine, feels really crappy and you're supposed to be taking care of each other, you probably don't want to both feel crappy and nobody wants to make dinner, and you know, it's nice to have somebody to take care of you when you're not feeling so good if you do have a reaction the next day.
Yeah.
So that's really a good point.
Yeah, so I just want to highlight one quick thing about that, and I forgot to mention this, is that patients with autoimmunity are now, at least based off of what most states have classified them, are not going to be considered as high-risk patients right now. So this is where you're looking at phase 2, tier 1B in Missouri. I don't remember what it is in Illinois. If you're in California, it's, you know, tier 1C or 2C rather. So I think that the issue here is that we are working at the state level, at least in Missouri, and to a certain extent in Illinois, trying to promote people with autoimmunity because of the medicines you take to be part of the high-risk vaccination group. I think a lot of this is going to be dependent on how much vaccine is available also. So again, this is a very fluid situation. And again, things may change tomorrow, may change next week. We have a new administration that has really vowed to get the vaccines out as fast as they can. So that could be another wild card that could change everything soon. So keep your ears to the ground, and especially on social media, where I think there's a lot of announcements about what's going on from the state level to people who follow those accounts. So this is, again, a very fluid situation. I get that autoimmune patients are really angry that they're not considered high risk. I agree. And so that's part of the reason why we're working with this, at least the state of Missouri, to be able to promote you guys to the high risk category.
Just a question again about Benlysta. I mean, if you're getting the infusion, should you wait a day or two, or is there some kind of, time frame between that and getting the vaccine, or does it matter?
Oh man, I don't know. I'm gonna flip that 10-sided coin, and whatever answer comes out, that's a tough question that we don't have a good answer to. I guess in general, we don't vaccinate on the days that people get their infusions, for flu or pneumonia. So that's one thing. So maybe, again, just because of habit, if you space it out by a couple of days if possible, it might be easier to change your Benlysta dose day versus changing your vaccination day because of how tight the scheduling for vaccination is right now. So, if it were me, yeah, I might wait a day or two. I mean, again, but that's just me.
Another question about your study: if someone has already had their 2 vaccines, can they still be part of your study?
Sorry, no, that's unfortunate.
Okay.
Yeah, we're willing. If you got your first vaccine, we do have some contingencies to be able to get you enrolled, because we can still get some of your blood before your second vaccine. But once you get your second vaccine, we're really looking at that date 1 week after you get your second vaccine to be able to measure your peak response. And so, but we need to compare it against something at least. So we need it before the second vaccine. Yeah, apologies.
What about the reverse of clotting, patients with ITP?
Well, ITP is another autoimmune disease, right? So that I treat as lupus, I treat as rheumatoid arthritis. So, I would vaccinate those people too.
How rare are side effects from the vaccine? Oh, I'm sorry.
Sorry, no, just the only thing is if you have a contraindication to an intramuscular injection. Oh. So if you're bleeding, if you have a bleeding disorder that is severe enough that that you're not getting intramuscular injections, which I think is pretty unusual, but that would be the only thing.
How rare are the side effects from the vaccine?
So there are side effects. So there's side effects and there's side effects. So almost everybody has some side effect. They have a sore arm, or they feel a little achy. Not as much the first vaccine. The second vaccine, I don't think, for some reason it seems like the older folks had less side effects than the younger folks. But everybody has a little bit of just, it may be just a little feeling off, but it could be as much as, like a low-grade fever and kind of muscle aches and pain, and your arm generally is fairly sore. So that's pretty common. Just like when you get the flu shot, almost everybody knows that you got the flu shot. The really severe side effects that would be incapacitating, those are very rare. And side effects that are unusual, we just really didn't see much at all.
Yeah. Again, there's a bunch of questions about your study, Al. So what if you're not part of BJC or WashU, what do you want to tell people?
I think we are more than happy to at least generate a list of people to be able to consider enrolling into our study. A lot of this is because of cost constraints. We can't enroll everyone. But I do really appreciate all these people wanting to help us, because this is everyone wants to know this answer. And so this has been the thing that kind of surprised me, maybe not because I'm cynical, but it's just because I think a lot of people are like, I'm not sure if I want to enroll in a research study. But we've gotten such a big response from the community. So I really do thank all the interest. I'm trying to think of the best way to compile names without blowing up my email, which I guess is already visible. I have no idea. But regardless, is that, and actually I can see right now someone's already emailed me about participating, which is fine. I think it looks like there's about 100 attendees. We have a team that can address this. So again, just either if Amy, you're willing to help serve as kind of a buffer for this, but also if you want to reach out to me, I will let this happen and entertain potential subjects.
Okay, so Lacey has put her said they can email her. Is that okay?
Oh yeah, that would be a lot.
Okay.
Yeah.
So
my email is a
you can
disaster.
Everybody get a pen. You can email Lacey at LACEYFEIGL@wustl.edu. I'll say it one more time. LACEYFEIGL@wustl.edu. Okay. And okay, we're going to do one last question, and this is one that I think all of us want to know. When is this going to be over? When can we get back to normal? When can we stop wearing masks and go to restaurants and hang out with our friends and go to the movies? And when do you all think we'll be able to do that?
You take this one, Rachel.
Okay, so I don't have a crystal ball. I can't tell you exactly. I think COVID surprised us and keeps on surprising us. I would think we would get. So the thing is, I'm not sure that we're ever going to go back to normal the way normal is. I mean, I think to some extent this has probably changed a lot about how people operate. I mean, I think work, for one thing, people now realize that they don't necessarily need to travel. They don't necessarily need to be in the office all the time. You can still get a lot of work done. So I suspect there will be a lot of things that change, period, in terms of when can you get together with your family, when can you go to the movies. I would say hopefully this summer we would start to see things opening up if things go the way, if we can really get people vaccinated. So there's lots of caveats to that answer. If we can get people vaccinated by the spring, if there's not some horrific, crazy variant that explodes and is resistant to the vaccines, which I mean, I think we have ways of dealing with that, but that might change. I think that's what most people are kind of thinking. The other thing to remember is coronaviruses. COVID-19 is a coronavirus, and they're winter viruses. They're your seasonal cold viruses, and this one is really acting like a really bad version of the seasonal cold viruses, and they go away in the summer. And we kind of saw that. We didn't think we were seeing that because we did such a bad job of actually protecting the population and getting people to wear masks. The other thing, though, is the not wearing masks anymore kind of thing. It would be fantastic if masks actually became more acceptable or more common, because the one thing that we have not seen this year is a big flu surge. So it's not just COVID that masks work for. Like, masks work for all those stupid respiratory viruses that make you miserable all winter. And so, if we normalize that kind of thing, that's not so terrible. But I do want to get to the point where my kids can go to school and I can go see my family and, and I can go back to traveling and that kind of thing. And I think I hope we will get back there, sometime probably this summer. That's my prediction. I might be totally wrong.
That would be great. I mean, and I don't know about the rest of you, but I haven't gotten sick at all. Like, I mean, because I'm wearing a mask all the time and I hardly go anywhere. So I haven't felt this great for a while. So fingers crossed. Okay, well, I want to, first of all, thank Rachel and Al for being here this evening and sharing their time with us. I found it to be very helpful, and I hope you all did too. Maybe we can again have another follow-up webinar in a few months and see where we are, and I'm sure that would be helpful. I did want to let everybody know that after this, in the next day or two, you'll be getting an evaluation. It's very quick and easy to fill out. If you would do that, it helps us in planning, sharing feedback with our presenters, and also helps us with our funders to show them that we are doing what we say we're doing. So we would really appreciate that. We're getting a lot of thank yous from people, and just saying thank you to both of you. So, and yes, again, we have recorded this session and we'll make it available on our YouTube channel. If you want to find our YouTube channel, just go to our website. It's lupus.org/heartland, and you'll be able to find our YouTube page there. But give us a couple of days, but we will get that up. So one more time, Lacey's email. It is, let me find it again. It's Lacey, L-A-C-E-Y, oh gosh, I'm sorry, let me find it again. L-A-C-E-Y, F as in Frank, E-I-G-L at wustl.edu. Okay. All right. Thank you, everyone. And we stay safe. Get that vaccine. Thank you. Bye-bye.